Consegue ver os meus
slides? Gravação.
Gustavo, consegue ver os meus slides?
Sim, eu estou vendo.
Just a minute.
Ok.
Sim.
You can start, Professor James.
Bem-vindos ao grande round do Hospital de Clínicas em sua versão virtual 2020, sempre em colaboração com a Faculdade de Medicina da Universidade Federal do Rio Grande do Sul. Hoje nós teremos um encontro internacional, o encontro será conduzido em inglês. Logo em sequência, então, eu vou estar fazendo a conversão da língua. From this point on, the meeting will be held in English. As we have been doing for the last 5 weeks, we will continue to explore the overwhelming disease COVID-19. Today's subject involves COVID-19 intensive care challenges and post-intensive care syndrome. It will be a dialogue between two university hospitals, the Vanderbilt Medical Center, University Medical Center, and the Hospital de Clínicas de Porto Alegre, HCPA. We will have two moderators. The American moderator will be Dr. João de Andrade, Professor of Medicine and Chief Medical Officer of the Vanderbilt Lung Institute. The Brazilian moderator will be Dr. Leia Fialkov, Professor of Medicine and Chief Medical Officer of HCPA Intensive Care Unit. We will have a meeting including 3 sections. The session 1 will be ICU care of COVID-19 patients. Session 2 will be randomized clinical trials in critical ill COVID-19 patients. And section 3 will be about post-intensive care syndrome in COVID-19 patients. Each session will have a brief presentation followed by questions and answers. Now I will ask John and Dia to introduce their respective teams and wishing successful meeting for everybody. Please, John, go ahead, and after you, Leah, present the team of President team. Please, John, go ahead first.
Thanks, James. Thanks, Dr. Fleck and Dr. Fialkov for the invitation. We're happy to be here. The Vanderbilt team is actually led by Todd Rice. Todd Rice is the director of our medical intensive care unit and well known in the world of clinical research in ICU.
John, please open your camera, please. I'm not seeing.
Can you see my slides? Hold on a second. I'm sharing my slides now, so. Well, let me keep going while I try to, so we don't lose any time here. Hold on. So, and then that'll be followed by Dr. Matt Semler, who is well known for his pragmatic clinical trials. And then Carla Sievin, who director of our ICU recovery clinic, will follow. Leah, while I'm trying to make this thing work, I'll let you present the team.
Okay, thank you, Professor James Fleck and João Andrade. It's an honor to participate in this grand round with the team of the renowned Vanderbilt University Medical Center regarding the support of the intensive care challenges to support COVID-19 patients. Thank you also, Professor Scott Rice, Matthew Sandler, and Carla Sabin for accepting to present and discuss each of the topics. From the Brazilian side, I invited 3 medical intensivists from our intensive care unit who have an expertise in each topic to foster the quality of our dialogue with you. These are Dr. Rafael Barbareno Moraes, is professor of the postgraduate program Epidemiological Sciences, Universidade Federal do Rio Grande do Sul. Dr. Tiago Costa Lisboa, professor of epidemiological science from the postgraduate program as well. And Dr. Cassiano Teixeira, professor of internal medicine, Universidade Federal de Ciências Médicas de Porto Alegre. I would kindly ask you to speak slowly for the better understanding of English. I believe that the interaction in this grand round has the potential to open doors for further collaboration between our institutions so that we can learn from your experience to help us in providing the best care of patients, their families, and professionals in this COVID-19 pandemic in our hospital. I now I invite Professor Andrade to moderate the grand round.
I don't know if you guys can see my slides. I'm having some issues with. Okay. Let me see if I can make this.
Yeah, I can see your slide.
Okay, good. So
I could see the slides.
hold on.
Is everybody seeing?
Can you see it? Okay. Well, I'm going to give you a brief introduction because the meat of the meeting is actually from Todd, Matt, and Carla. I'm going to give you a brief overview of what has happened in our city, in our medical center. The city of Nashville had its first case on the 5th of March, and 11 days later, the bars downtown closed. You can see here what happened when the bars were closed and we had no one. And that was shortly before St. Patrick's. So we think that actually helped us tremendously. 4 days later, the school closed and the first COVID-19 related death occurred. It was not until April 2nd that we had a stay-at-home order by the governor. And 1 month later, on the 11th of May, the reopening of the city started. This is the curve for the state of Tennessee. You can see here that early March, the cases were going up significantly, and this is around the time that we had the stay-at-home order, and the curve was flattened. In terms of what happened at UMC, after we learned of what was happening in China, the administration began preparing, and around January 2020, we built a new screening and treatment area for the emergency room in one of the parking lots, and that area became a screening facility for all the employees and also for an extension of the emergency room. On March 11, no visitors were allowed. On the 18th, students were ordered to stay home, both medical and nursing. On the 19th, all elective procedures were postponed. And on the same day, the hospital limited entrances, and all employees were having temperature checks, and that remains in place until now. By the end of March, we received the order to wear masks while in the COVID unit. And a few days later, the order was for everyone, everywhere, to use masks. And by March 11, all admissions, whether they were symptomatic or not, are being tested. In terms of our preparation in the intensive care area, this is the Medical Center East Tower. The 8th floor was turned into a COVID unit, 37 beds, both ICU and acute care. And the beauty of this is that the 8th, 7th, and 6th floors of this building had been prepared with electrical and gas piping in a way that they were able to receive ICU equipment in short notice. Our MICU has 34 beds, 3 services, 2 teaching services, 1 non-teaching service. And essentially what we've done was create an extra teaching service and expanded our non-teaching services into the COVID unit. So that is the brief overview of what happened in the city, the medical center, and the ICU. And with that, I turn to Todd.
All right, let's see if I can do this.
I'm going to stop presenting so I can turn to you.
I'll turn my camera on. I'm not exactly sure what that's going to do, but
yeah, you have to. There's on the white bar in the bottom. There's something that says "Present Now," and then you can go from there. There you go.
Can you see or no?
Yeah, we're good.
Yeah, we are seeing now.
You have to put on a slideshow.
Very clear.
Yes, still good?
Yep.
Okay, well, thanks for having me, and hopefully this will be informative to you all. The opportunity to ask and answer questions, and just kind of give you our experience and our take of the literature. So I work for a couple companies. None of them do anything with COVID. So just get that out of the way. The disease course, as you guys probably know, ranges from asymptomatic patients who we're finding now because we're testing everybody that's coming into the hospital, to patients that have mild symptoms, sometimes fever, cough, a little bit of shortness of breath, but not necessarily hypoxia, to moderate symptoms where patients have some hypoxia and get admitted to the hospital, usually with some abnormalities on their chest x-ray. And then the place that we actually see them is in the ICU when they have severe symptoms. They usually have severe hypoxia. They have ARDS and maybe other organ failures, although as you'll see, those are somewhat less common in this disease. So what we know about the epidemiology and the critical ill, it's a little difficult to ascertain the actual incidence. Initial reports said 20% of the patients, but I think that was just hospitalized patients. And now if you look at broad testing, it's probably someplace in the low single-digit percents of the infected. I put in the slide 2 to 5% of the infected. This has been pretty consistent across countries and hospitals, that it's about 15 to 20% of the patients that get hospitalized end up in the ICU. So a little less than 1/4 of the patients that are hospitalized. Risk factors for worse disease are pretty clear now: male gender, hypertension, diabetes, cardiovascular disease, and then the elderly. Risk factors for death are very similar: male, cardiovascular disease, and the elderly. And there's a bunch of prognostic biomarkers that number of studies have shown are associated with worse outcomes. You can see them listed: D-dimer, ferritin, LDH, etc. None of these are known to be causative, and it's not entirely sure what to do with elevated biomarkers other than say, I'm worried about that patient, but we're not sure how it affects the treatment. There's a phenotype, pulmonary phenotype. The phenotype is a severe rapid onset of hypoxemia. Oftentimes it's pretty asymptomatic for the patient, so we call it silent or happy hypoxemia. The patient oftentimes has told us they don't even feel short of breath, even though their oxygen saturation is below 80%, for example. The chest x-ray shows diffuse bilateral infiltrates that's consistent with ARDS. Some patients actually have higher lung compliance than we might used to see or be accustomed to seeing with patients with ARDS. The course is rather prolonged. We'll get into kind of what the time course is in the next couple of slides. And then there are these characteristic, what we've called COVID spells, which are periods of refractory hypoxia. And getting into detail on these COVID spells, they usually have an abrupt onset. They appear to be refractory to increasing FiO2, PEEP, or mean airway pressure. If the patient's on the ventilator, we often find they're accompanied with hypotension at the same time. They're not usually associated with fever. Patients with this get worse when they have fever or when they're agitated on the ventilator, but these COVID spells appear to happen without fever and without apparent agitation. They do sometimes respond to deep sedation and paralysis or paralysis, and then they can last anywhere from a few minutes to sometimes even up to an hour and a half, up to 90 minutes. So they can be prolonged periods of refractory hypoxia. These were puzzling at first for a lot of people, but I think this article may have an explanation. So this is an article in Lancet Infectious Disease that's in press. And it shows from some novel CT scanning that what these patients have is abnormal pulmonary vasodilation at the areas where their disease is. So you can see in the figure on the right, the red is the vasodilation in the areas that are more perfused, and those correlate well with the area of disease, diseased lung on the left. And so these patients have shunt, and a fair amount of shunt. And I think these COVID spells are increased blood flow through these areas of shunt. And that's why they have refractory hypoxemia, is because the area of shunt doesn't see any of the oxygen or PEEP that we're delivering. So how do we treat these patients? So this is the American Society of Critical Care Medicine's summary of recommendations on the initial management. So COVID-19 patient with hypoxia, do they have an indication for endotracheal intubation? If so, do the endotracheal intubation. And I know you guys have some questions about that, and we can talk about it during the question part. If they don't have an emergent indication and they're tolerating supplemental oxygen, give them supplemental oxygen. If they're hypoxic on just supplemental oxygen, consider high-flow nasal cannula. And we are using high-flow nasal cannula in these patients. And then if they don't tolerate high-flow nasal cannula, we actually will do a trial of non-invasive ventilation in these patients, and I'll show you how we do that. And if they're markedly hypoxic and or distressed on either high-flow nasal cannula or non-invasive ventilation, then we will intubate them. And that's our indication for endotracheal intubation. We don't think you should delay intubation beyond what you would kind of normally do. Maybe a little bit more tolerance for these COVID spells. But ultimately, if a patient has fairly persistent hypoxemia and or distress, they should be intubated. But we also know that there were some recommendations to intubate early and ventilate early and not use high-flow nasal cannula and non-invasive. And we did not follow those recommendations. We used high-flow nasal cannula and non-invasive, and it's had a number of our patients prevented them from requiring endotracheal intubation and not needing mechanical ventilation. We think overall the care for these patients is good care for typical ARDS patients. So it's evidence-based management of, you can even take the COVID out, just bad ARDS. So you get admitted to the ICU, you support them with high-flow nasal cannula or non-invasive ventilation. If they get intubated, you use low tidal volume or normal tidal volume, 6 mils per kilo predicted body weight tidal volume. You use higher PEEP. We use the ARDSNet higher PEEP ladder. If they still have hypoxia, we prone patients, especially in the first 24 hours, so early on. And we do 16 hours prone and 8 hours supine. Steroids we don't use routinely, only if you have another indication. So COPD, asthma, if you are on steroids or you have refractory shock. Diuresis, once you're stable on the ventilator, usually after the first day or so, we will gently diurese to get some fluid off to try and improve oxygenation. And then, and this is really important, I think, doing spontaneous awakening, spontaneous breathing trials daily if it's safe for the patient to do so. This is a little harder in these patients because they're in a bunch of isolation and you can't go in and see them as much. And you really have to have a nursing staff or somebody at the bedside that's really kind of aware and very, very in touch and watching the patient while we do this. And we don't let the patient, we don't let the patient have to go a long time on these. If you're going to do 30 minutes, be ready to extubate at 30 minutes. If you're going to do an hour, be ready to extubate at an hour. Here are the data from Jack Awashna's group. This is actually on medRxiv. It's not published yet in print, but it's on medRxiv, suggesting that the high-flow nasal cannula does not aerosolize particles of different sizes, but no size, any more than regular face mask, 6 liters nasal cannula, or even breathing room air. There's a bunch of figures in this article, and this is just the one I showed, but pretty much every way they measured it, the aerosolization, the particle size, the aerosolization with coughing was very, very similar when you were on these high flow 30 to 60 liters compared to when you were on lower flow oxygen or room air even. And these are 3 different patients. This is a female patient or subject and then 2 male subjects that they did this experiment in. I told you I'd show you the BiPAP. Here's the BiPAP setup. This is not ours per se. This is one of my colleagues, but this is how we do it. It's a mask that fits over the nose and the mouth. And then we put a filter, a bacterial and virology filter on the expiratory limb of the BiPAP to filter the expiratory air that's coming out. We call it closed circuit BiPAP. So there's a lot of talk that there's an L and an H type of this disease and that the compliance is different and that maybe we should treat them differently. And the next 2 slides, I'm just going to show you data that suggests that that's actually not the case. This is respiratory physiology data from Mass General and the Brigham hospitals in Boston, 66 ventilated patients. They did their respiratory physiology for the first 5 days. And you can see that these are very, very consistent with the respiratory physiology for patients that we normally put in ARDS trials and that we normally care for with ARDS, including plateau pressures that are in the mid-20s on average, some above 30. There are these that are a little bit lower in some patients, but we see these in all of the trials that we've done of ARDS. Here's another one from a group, I believe, in Sweden that actually looked at CT scanning compliance and whether the aeration of the lung correlated with this compliance. And here is classic H phenotypes are these kind of pink diamonds, and the classic L phenotype, as described by Gattinoni, are the blue diamonds. And you can see there's a patient that fits in the classic L phenotype and a few that fit in the H phenotype. But the vast majority of patients have discordant results, meaning that they don't fit in either the H or the L phenotype as it was described. Their conclusion from this is that there's no suggestion in our data that the HL phenotyping schema accurately describes patients with COVID-19. If you guys want to, I can send you these slides through JAO, but here's sort of an algorithm put together by a colleague of mine on how we treat these patients. So ventilation, low tidal volume ventilation, high PEEP, prone positioning if you need it, fluid management, don't resuscitate unless there's marked signs of hypovolemia, although some of these patients are hypovolemic because of the course of their disease. Pressors if they need it. If they're not on pressors and they have refractory hypoxemia, give them Lasix. And if it doesn't work, think about hemodialysis. Then sedation, light sedation, unless you're doing proning or they're desaturating, in which case heavy sedation and neuromuscular blockade if needed. So a couple slides and then I'm done on the non-pulmonary phenotype. So there's a couple non-pulmonary things that we're seeing in critical care. One is volume depletion. We see more of this than we normally do. That's because they have increased insensible losses, decreased PO intake, and for many of them, their time course before they get intubated is often prolonged. It may be a week or longer. There's reports, as you've probably seen, of clots in a hypercoagulable state, strokes and venothromboembolic disease. There's reports of cardiomyopathy, although I'll be honest, we haven't seen it, and most of our colleagues in the U.S. have seen very, very little of this. There's renal failure that we'll talk about briefly and some altered mental status. And then the last slide, I'll talk about co-infections. So the hypercoagulable state is present, at least by reports. We're trying to get a better understanding in the scientific community. There's reports of increased incidence of large clots, so DVTs and PEs, in at least one small autopsy case series. But why this happens, I think, is still to be determined. And whether or not patients have hyperactive platelets or they're hypercoagulable from factors, their clotting factors, or if it's fibrinogen or what it is, I think is still to be determined. And I think it's also undetermined as to what this means and whether or not we can help these patients by systematically treating them, whether it's giving them anticoagulation or antiplatelet agents or what. Cardiomyopathy, I told you, was reported from early centers, occurs fairly late in the course. It's characterized by a sudden, unpredictable shock and death, low biventricular ejection fraction, but it's kind of unknown how frequently this is really happening. Renal failure is interesting because although we see renal failure in critically ill patients, this is a little different in that it's a really sudden onset of anuria and just rapidly progressive renal failure. Reports are that it's in 30 to 50% of patients. We've had a number of patients actually recover their renal function, usually after their lungs recover and they come off the ventilator. And there are a bunch of hypotheses that I won't go through as to why this is occurring, but people are suspected of the things that are listed there. The last thing I'll talk about is co-infections. There's some viral co-infections on presentation. So we were in respiratory virus season, the end of it. When we started this, we saw some co-infection with rhinovirus and enterovirus. There's really not much bacterial co-infections, especially on admission. We're seeing some iatrogenic a week or 2 weeks into the course, but not really on admission. And in fact, reports are that these patients have low procalcitonin levels, suggesting that they don't have a bacterial infection. There are some iatrogenic infections that we talked about, VAP, MRSA, gram-negative rods. And then there are emerging reports of some Aspergillus pulmonary infections, which we saw with H1N1. And I think we'll hear more about those in the next few months as to how real those are and how frequent the incidence of those are. Outcomes. So in reports, most patients are ventilated, almost universally ventilated. Up to half of the patients require proning. The duration of ventilation is prolonged. It's between 2.5 and 3 weeks. 1 to 3% require ECMO. About half require pressors. A third or so get renal replacement therapy. And overall hospital mortality of the ventilated patients is someplace in the range of 17% reported from Boston to maybe 40% reported from New York, the Columbia Hospital System. So that was what I was going to go through. There's some bibliography here that we can send you of just the literature that's to support it. You can see a bunch of this is not even published yet. All of these are in EPUB to head of press. So it's a fast moving field. I'm happy to take questions at the end.
Thank you, Todd. You guys want to roll over to Matt immediately?
Can I make some questions? Make 1 or 2 questions.
Yes, please. We can go for questions now. Go ahead, please.
So, firstly, thank you, Dr. Todd, for your presentation. Your lecture goes in the same way as your letter recently published at the journal that calls for us to keep in doing evidence-based medicine and not fear-based medicine. We are seeing lots of people changing our daily practice that are decreasing the mortality of our patients through the last 3 years.
Yeah.
So congratulations for keeping doing this in these difficult times. I'd like to hear from you, basically, what changes have you made in the intubation process, and your role as a leader to keep doing these interventions based on the evidence-based medicine in this time of fear, in this time of that people are so prone to change their interventions based solely in small cases and series of cases and observational data.
Yeah, let me address the intubation first, and then we can talk about the second. So I'm at a teaching hospital. We have fellows that are in training. Before COVID, the vast majority, probably 99% of our intubations in our ICU were done by the fellow with faculty supervising them. We have anesthesia backup at night, but all of the daytime intubations are done by us, mostly our fellows. During COVID, we changed that policy to what we called the 2 most experienced operators. So we have 2 very experienced operators that are present for the intubations. That is almost always 2 faculty now, than their experienced faculty. So that's one change. The second change, and Zhao had sent some questions, and you all are exactly right. We published a manuscript, a study in the New England Journal last year about bag mask ventilation and decreasing hypoxia. And we actually don't do that in our COVID patients for fear of aerosolizing the particles. So we do a RSI, we push meds, we don't bag, we look with their laryngoscopy, and we use a McGrath. So we use video laryngoscopy because we think it keeps you a little further away from the patient. Intubate them, put the balloon up, and then bag them afterwards once we have a secure airway with the balloon up, and then change them over to the ventilator when their oxygen saturations are higher. So it's a little bit against our publication in this era, and we're doing it because we think it's potentially safer to us and to healthcare workers, not because we think it's the right way to necessarily intubate a patient. It's sort of a compromise for the scenarios. The second thing I'll say really quickly is that the evidence-based medicine, I'm fortunate to work with a great group of colleagues who are partly here because I think they believe in evidence-based medicine. And so they're on board with doing that. And one of the ways that we do that is we have lots of protocols in our ICUs so that the ICU runs fairly independent of who the physician attending is. So we have ventilator protocols, weaning protocols, sedation protocols. And we've emphasized through this that we should continue to use those protocols. Those protocols are how we care for patients. And the phrase that we've sort of emphasized is do what we do and do it absolutely as well as we can. And that's sort of the mantra.
Todd, I'm curious about something. What is the rationale behind the prone position?
Yeah, so the physiologic rationale is that you change some of the way the breath is distributed based off of the bucket handles from the ribs and the pressure from the spine so that the air gets distributed. The mechanics of breathing are a little different. But ultimately, I think for me, it's all about VQ match, and it better matches ventilation perfusion. And that's the thought process behind it. We don't use special beds. We turn people over on the bed that they're on. It takes a lot of staff. It's a lot of hands on deck to do it, and it takes learning positioning. So we got help from our colleagues in the operating room who are used to doing surgeries prone to help with padding and where the pressure points are and all of that. But I think the rationale behind it is changing the respiratory mechanics a little bit and matching ventilation and perfusion better. Matt may have some different thoughts. I don't know, or Carla.
Okay, we come back to John now. John?
Okay, any other questions, folks? Or if not, we can let Matt go through his slides. Matt, you have the floor.
Great, and you all are able to hear me okay?
Yeah, can I hear you?
Perfect. Well, I appreciate the opportunity to talk with you all. I'm Matt Semler, and I work here at Vanderbilt with Joao and Carla and Todd in our medical ICU, and most recently in our COVID ICU. And the section I'm talking about today is randomized clinical trials for critical illness from COVID-19. I have no disclosures. And so I start with the same conceptual framework for COVID that Todd showed you. And this is a little bit different for us because we're critical intensive care physicians, and all of our research tends to focus on patients all the way on the right here who have severe disease, delirium, shock, ARDS. But I think in order to understand COVID and to develop therapies that are effective in preventing or treating critical illness from COVID, we need a conceptual framework of thinking of this illness as this full spectrum. So that starts with the invasion and replication of the virus, and then virus-induced tissue injury in the early parts of the disease, and then probably an inflammatory injury that has nothing to do with the virus and organ dysfunction that's later on. And how that might manifest for the patient is the patient who's asymptomatic but infected, where the goals of research might be to prevent symptoms or transmission. The patient who's infected but only has mild symptoms out in the clinic, fever, cough, shortness of breath, for whom the goal of research, the goal of treatment might be to improve symptoms or to prevent hospitalization. The patient who has moderate symptoms, maybe who has pneumonia on imaging, hypoxemia, who's in the ward of the hospital, for whom your goal might be to improve the World Health Organization COVID outcome scale or prevent progression such that you prevent use of the intensive care unit. And then finally, the patient with critical illness, severe COVID, who has delirium, ARDS, shock, AKI, venous thromboembolism, and whom your goal is to prevent death, facilitate liberation from the ventilator. So the trials I'll talk about today, although we're a critical illness group, span the whole range of that disease process, viral disease process, and severity of illness. And I start with the premise that no effective disease-specific therapies for COVID-19 exist. So supportive care is probably helpful. And I think there's some lay press data that suggests that remdesivir may be helpful. We'll talk about that. But as of today, there's no approved medication for COVID. There's no trial that shows a medicine is beneficial for COVID. So every patient at every stage of the disease is potentially eligible for a trial to figure out which therapies work and can help treat patients with. With that in mind, we've kind of designed 3 domains in which we're interested in studying COVID therapies. The first domain is antivirals, and you might see how medicines like hydroxychloroquine, Kaletra, plasma, remdesivir might be more effective during the phase where invasion and replication and viral tissue injury is the dominant pathology and might be less effective once critical organ injury and critical illness have onset. The second domain is immunomodulation, so medications like tocilizumab, steroids, baricitinib that are addressing the inflammatory or cytokine pathways might be more effective in that moderate stage or the severe stage. And then supportive therapies like prone positioning, anticoagulation, high-flow nasal cannula, which might be targeted at organ dysfunction later in the illness. And I'll walk through the examples. There's so much research going on in this. I'm only going to talk about the trials that we're enrolling here at Vanderbilt. So I'll walk through examples in each category that we're actively enrolling patients in. The first of those is a trial of hydroxychloroquine, a potential antiviral for COVID. And I'll skip the rationale and the background for this. You all probably have heard in the lay press or are familiar with why hydroxychloroquine might make sense as an antiviral. But we have no data to suggest that it works in any virus, much less COVID. And so we designed a randomized double-blind placebo-controlled trial that we're running through the NHLBI PEDAL network at 50 centers in the United States. It enrolls hospitalized adults with laboratory-confirmed COVID for less than 10 days, trying to focus on the earlier part of the illness. And the intervention is hydroxychloroquine 400 milligrams for 2 doses and 200 milligrams for twice daily for 8 doses, so 5 total days of therapy. Primary endpoint of World Health Organization COVID ordinal outcome scale on study day 15. And our sample size is 510 patients. This has some similarities to the trial that of hydroxychloroquine versus placebo that I believe the Brazilian critical care group has finished enrollment in. I mentioned our eligibility criteria. The main things that we are focusing on is hospitalized patients, laboratory confirmed COVID, symptoms of acute respiratory infection, and then excluding the patients who have a QTc more than 500 milliseconds because of the risks of torsades, and those who have received more than 1 dose of hydroxychloroquine before enrollment. I mentioned patients get 5 doses of drug, and our main outcome is the WHO COVID ordinal outcome scale, which goes from the worst outcome of death all the way down to the best outcome of not hospitalized, no functional limitations. And this is as of yesterday. We'd enrolled 309 patients, and our hope is to be done enrolling sometime in early June. So that's the ORCID trial of hydroxychloroquine. That's focused on patients in the hospital, some of whom are critically ill, so a little bit later, but we also want to be evaluating the earlier phase, so where patients are minimally symptomatic or even at home. And so there's a trial that Todd is leading of hydroxychloroquine and Kaletra This is a multi-center randomized double-blind placebo-controlled 3-arm trial looking at non-hospitalized adults, again, laboratory confirmed COVID, early in the illness, right? First 6 days, randomized to hydroxychloroquine, 400 milligrams for 2 doses, then 200 milligrams for 8 doses. So that same 5 days of therapy. That's intervention 1. Intervention 2 is Kaletra, twice daily for 14 days. And then the primary endpoint is that same or a similar COVID ordinal outcome scale on study day 15. This is intended to enroll 900 patients. Eligibility criteria we mentioned, and it excludes patients who are hospitalized or have contraindications to Kaletra, like known HIV, end-stage renal disease, end-stage liver disease. This is a unique trial in that it's not patients in the hospital we're directly interacting with. The drug is delivered overnight by mail. The outcome scale is similar to that used for the ORCID trial, and a lot of the daily symptoms are collected via smartphone apps rather than in-person assessments and records of any hospitalizations or that's those 2 trials involving hydroxychloroquine. Todd's also leading a local trial here of convalescent plasma that we hope to expand out to the PEDAL network. The brief summary of the Pass It On trial is that it's a randomized, partially blinded, placebo-controlled trial of hospitalized adults. Again, laboratory confirmed COVID within 14 days of symptom onset. And the intervention is pathogen-reduced convalescent plasma. So patients who've gotten SARS-CoV-2 and are confirmed to have had that donate their plasma to a laboratory here where it's evaluated and then administered in the intervention group. Placebo group is the lactated ringers with multivitamin that's the same color as the plasma. And again, the outcome is the WHO COVID Ordinal Outcome Scale at study day 15. Intended sample size is 500 patients. This trial has a unique funding source that is not what we're traditionally working with. It's funded by a generous gift from Dolly Parton, the famous country singer who has been supportive of the work on COVID in Nashville here. So this is not our federal funding. This is country music star funding. Eligibility, the goal is really to find patients in the hospital who are clinically worsening. And so many of our intensive care unit patients end up receiving, being enrolled in the Pasadon trial. Quickly, the last antiviral I'm going to talk about is remdesivir, and we'll pair this with the only immunomodulation therapy we're studying. This is part of the ACT-1 and ACT-2 trials that are sponsored by the NIAID. So this is an adaptive trial that started early and was enrolling at many centers around the world, and so we're just contributing to this trial. We're not leading it. The ACT-1 trial evaluated remdesivir versus placebo, and although the formal results of that are not yet published and peer-reviewed or even submitted to my knowledge, our government has had a press release about what they appear to show, which is that remdesivir compared to placebo appears to shorten the duration, the time to recovery from 15 days to 11 days. And it looks like there's a potential mortality benefit that is in the range of 2 to 3% in absolute reduction with a p-value of 0.059. So it will really take some careful review of the final manuscript after peer review to know what to make of this, but it's been enough for the investigators in Act 2 to move from a trial of remdesivir to placebo to the second phase, in which patients receive remdesivir in the intervention group and in the control group. So the intervention is baricitinib with remdesivir. Baricitinib is a JAK2 inhibitor that may prevent the cytokine generation and cytokine storm, and remdesivir is the antiviral, so both groups get that antiviral. So we are enrolling patients in that here as of this week and have enrolled several patients, but the inclusion criteria are much more restrictive. I think, though, this is a good example of how this research should work. The instant we find something we think is effective, like remdesivir, the next study makes that therapy standard of care and available to patients in both groups, so that it's building on the research offers the opportunity to build and standardize standard of care and make sure we're delivering the best therapies routinely to patients. And then the final topic I'll just mention is a therapy within the organ support category, and that's prone positioning. So this is a trial being led by Todd, but with one of our fellows who's doing a lot of on-the-ground work, Eddie Chen, and this is a randomized open-label trial, hospitalized adults, laboratory-confirmed COVID, and receiving oxygen. And it's a very simple trial. Patients in the intervention group are asked to prone themselves. So these are largely awake patients, alert patients, often on the floor. The goal is to prone themselves a lot. So for 3 hours, QID. A control group, no formal request is made, no suggestions about proning, so they're allowed to change their position if they choose to. And the basic endpoint is the level of support at 5 days. And the sample size is aiming to be 300 patients. And the question is basically, by proning and redistributing blood flow and hopefully improving oxygenation and the amount of FiO2 administered, and perhaps receipt of mechanical ventilation or other therapies, that you can decrease the level of support required by patients on the 5th day. And our hope with this is the last slide, is that by using this unique moment where we know essentially nothing about disease-specific treatments for COVID, rather than using compassionate use of medications that might not work and might be harmful, or not allowing our therapy patients access to COVID-specific therapies. We do the work to stand up these trials so that we're learning very rapidly, and a month from now, we have therapies. Maybe we've crossed off this list. Maybe Kaletra and hydroxychloroquine doesn't work, but remdesivir and monoclonal antibodies do. And so the patient who comes in, we've moved from this area of limited knowledge and a lot of variation in care to a point where we can standardize care and be delivering therapies that we know are effective. So that's our hope. I appreciate your time, and we're happy to take any questions.
Thank you, Matt. Any questions?
Hello. Can you hear me?
I can hear you.
Okay. Thanks, Matt, for the excellent presentation. We have a few questions here, and I think that your experience in Vanderbilt as an excellent center for clinical research can help us a lot. How are you dealing with the informed consent process in the scenario of pandemic? Patients most of times came already in mechanical ventilation. The family cannot be around. So what's your experience? How are you dealing? How are you using this scenario in designing your clinical research?
Matt, you're muted. Yeah, good.
Are you able to hear me?
Yeah.
So the question about how to do informed consent when there's an illness that's transmissible that the patient has that you don't want study personnel to receive, and you don't want to be using personal protective equipment for research if it's limited and you want to be using it for clinical care, and the patient's family members or legally authorized representatives are not allowed to be physically present. It's really challenging. What we've done is developed a set of tools that allow us to perform written informed consent despite those challenges. So, for example, we've developed through the REDCap, which is the database that we host at Vanderbilt here and use frequently, now has a set of e-consent tools in it that allow us to, if the patient has a smartphone or the patient's loved one at home has a smartphone or a computer, we can perform the entire consent process over the phone with the signatures being recorded in REDCap on their home computer, and can get a valid written informed consent even if the legally authorized representative is 100 miles away at home on their computer. We have, so that the e-consent is one module. We also have a scanned consent, where if they don't have the ability to complete it electronically, they can sign a written informed consent, and we can work to basically upload a photograph of that into the REDCap database. And then the third is that in cases where those two don't work, our Food and Drug Administration has allowed to basically the study personnel and an independent party to attest that written informed consent was signed as the way of documenting that. So we've developed a whole new process for informed consent. And those tools through REDCap should be publicly available. So the goal is to be, as we make these things, make them available to all. So that's been a big challenge in this area. But we've enrolled all of the 316 patients enrolled in the ORCID trial have been enrolled with one of those 3 new modes of consent that we didn't have 8 weeks ago.
Matt, you may want to add that the prone positioning trial is pragmatic, so I don't think consent is required. Right?
Yeah, that's true. So some of these trials, like ORCID, a double-blind, placebo-controlled, randomized controlled trial, requires written informed consent. At the far end of the spectrum are comparative effectiveness studies in which the patient's executing the intervention where a written informed consent is not required, and in fact, consent is waived. So we have that whole spectrum, but I think we've had to develop tools that allow us to do written informed consent in this, which is a new challenge.
Okay. Thank you so much for the questions. Given the hour, let's move on to Carlos' presentation.
Great. Thank you, Joao. And thank you, Brazil, for having us. It's a pleasure. Our time is really short, so I'll just jump in. I am Carla Steven. I'm sorry, my Google name came up as Christian Schutz there. That's my husband, not my nom de guerre. But I'm going to focus on the outpatient treatment of recovering from critical illness. Can you all see my slides?
Yes, we can see your slides.
Okay, great. And I'll just start out by saying that most of what I'm going to talk about today is based on our clinical experience with the post-ICU clinic and some early research efforts, which are even more scant than what we know about COVID these days. We're just starting to see our COVID patients, and so far their post-ICU recovery is not significantly different in kind to those patients we saw recovering from critical illness pre-COVID, but perhaps in degree of impairment. And despite the a lot of talk about mortality in COVID-19, the fact is most of these patients will survive, even the ones who become critically ill. And we know from previous research that the burden of survivorship is high after critical illness. So we are, of course, very focused on survival, and rightly so, but our job is not finished once people leave the ICU. And especially for patients and families, survival is not the endpoint. Even pre-COVID, we were discharging 6 million survivors of critical illness into the community every year without any specific follow-up. And that has resulted slowly in some increased awareness of the so-called post-intensive care syndrome, which is basically a name we applied to this constellation of impairments, physical impairments, cognitive impairments, mental health impairments, and effects on families, as well as high burden of chronic health conditions and healthcare utilization following a discharge from the hospital. So how is recovery from critical illness different in COVID-19? This is a study of movement in ICU patients done by Bjorn Kamdar, who was one of our residents here at Vanderbilt and did his fellowship at Hopkins and is now out in California. But he put actigraphs on a bunch of critically ill patients as well as a healthy control, which was, I believe, himself. So in the top panel here, A, you can see how much a healthy control person is moving around during the day, activity being on the y-axis and time being on the x-axis. And this lower panel is a conglomerate of about 24 critically ill patients in the ICU. And you can see that they're basically not moving at all throughout the 24-hour epoch. Now in the time of COVID, we have decreased ability to, as Todd alluded to, run in and take care of patients who become agitated when their sedation is lightened. So we're seeing increased use of sedation. We've had some drug shortages here in the US, resulting in the increased use of benzodiazepines in some patients. These, of course, along with the severity of illness itself, have resulted in increased time on mechanical ventilation. Some of these patients, I think Todd put a mean duration of mechanical ventilation of 18 days in one of his slides, so longer than average for ARDS. And all of those factors work together to decrease mobility even further. We have decreased family visitation, which worsens delirium, and our resources and our staff are quite stretched, so we don't have the aggressive physical therapy, occupational therapy, speech therapy, mobility that we would like to have under optimal circumstances. And to be honest, even pre-COVID, I felt like those were insufficient. So in 2012, we opened this ICU recovery clinic, which was really dedicated to trying to help people get the optimal recovery after critical illness. It's a multidisciplinary team made up of respiratory therapists, ICU pharmacists, critical care physicians and nurse practitioners, neuropsychologists, and case management services. And we are very focused on the sickest patients we see in the ICU, those who've either been on mechanical ventilation, in shock, or delirious. Of course, many of our COVID patients are all three of those. So as I mentioned, we've just started seeing some of our survivors back in the clinic, which is currently all telemedicine. and we're able to pull in each of these team members using Zoom, which is connected to the medical record. So that's been very successful. We've actually been able to reach more patients this way than we have been able to previously by bringing people back to the clinic in person. And in fact, pre-COVID, we were doing a telemedicine study comparing telemedicine to usual care for this type of visit. And so we were up and running and ready to go seeing patients in a team clinic via telemedicine on day one. This is our clinic layout. It's quite a long visit when we see them in person, about 2 hours. We bring them in, do a spirometry to look for underlying breathing problems. About half of our ICU survivor population are smokers or former smokers. About a quarter of the population in Tennessee smokes. And we're looking for airway issues related to long-term ventilation. They have vital signs. They do a 6-minute walk test to get a gauge of their physical weakness, which is profound in most patients. They get a thorough medication reconciliation by our pharmacist and a medical history and exam sort of debrief of what happened to them in the ICU, a neuropsychology evaluation, which includes evaluation of their cognition and screening for anxiety, depression, and post-traumatic stress disorder. A case management evaluation. Unfortunately, despite being a pretty wealthy country, we have a very poor healthcare system in that it's fragmented, and many of our patients are uninsured and they don't have access to the care that they need to recover in the outpatient setting. And that has only been heightened in the COVID era with widespread unemployment. Many people who did have insurance no longer having insurance. And even if they do have insurance, don't have access to the services they need because things are closed down. And there's a lot of fear in the community about seeking medical care. We assess and discuss the plan with the patient and the family members. We get feedback from the patient and the family. We notify the primary care physician of our findings if the patient has one. And in about half of patients, they don't have a primary care physician, so we have to help them set that up. And then we record our data in a quality database. Of course, the physical sequelae are probably the most obvious to us as physicians. This is one of our patients who was seen a few years ago after spending 4 months in the ICU. He was a young patient who lost 126 pounds during his ICU stay, and you can see he's still requiring a wheelchair, quite debilitated. He's got some braces on his ankles, which you can't see, for foot drop and critical illness neuropathy. And his partner is there with him. This is one of our nurse practitioners. We commonly see pretty severe pressure ulcers, especially in people who have received ECMO or been paralyzed for a longer period. So we're seeing more of this in the COVID era. Just the alopecia or hair loss is very disturbing to patients, as are nail changes. So these are self-limited and of course benign, but as something that patients are very relieved about when we tell them that they're self-limited. Shoulder impairment is actually a big problem after critical illness. We generally do not have patients putting their hands above their heads throughout their hospitalization, and frozen shoulders, stiff shoulders, pain in the shoulders, decreased mobility and weakness are quite common. And I expect to see more of this with increased use of proning. And that's already been described in some centers. Cognition is, in a general ICU population, pretty impaired. We are anticipating, because of the factors mentioned previously, longer durations of delirium and thus increased cognition impairments after critical illness with COVID-19. And you can see here that even in a mixed ICU population, that the average impairment in cognition as measured by the R bands is in the level of traumatic brain injury, or between mild cognitive impairment, which is this orange line, and Alzheimer's disease, which is this blue line, which is pretty bad if for something that did not directly affect your brain. Of course, we have concerns that COVID does directly affect your brain, and that's under investigation. but even in the younger patients, this is the younger than 49 years old age group, age was not protective. They still had significant decrements in their cognitive function. And we know that delirium is the strongest independent predictor of cognitive impairment, which is why we're so aggressive in trying to manage ICU delirium in the ICU. Post-traumatic stress disorder is also quite common after critical illness in general. As we've been talking to patients and their family members, the risk factors for this, we know that the comorbid psychopathology, so pre-existing psychologic disturbance, the use of benzodiazepines, and early memories of frightening ICU experiences do increase the risk of PTSD, and these are all heightened in COVID. So our time is really short. I just want to mention that many of these patients, even pre-COVID, were sort of lost in this no man's land between a family doctor outpatient setting and the inpatient setting, resulting in frequent rehospitalization. And there are a couple of ways that we've tried to address this problem. There are very few post-ICU clinics worldwide, and including in the US. There are starting to be more. And we feel very lucky to have one here at Vanderbilt. I think the increased use of telemedicine is going to be of benefit in this sense. In the meantime, for those places who do not have a post-ICU aftercare program set up, Jack Iwashina and some of my colleagues who work together on post-ICU care came up with this dirty dozen, 12 points to cover prior to a patient going home. And we can send these slides ahead so you can look at this in more detail. These are the top issues. We found a couple years ago that even just talking to patients about their recovery trajectory and what to expect with post-intensive care syndrome type symptoms actually resulted in a trend toward decreased readmissions, especially in this early 7-day period after hospital discharge. This is a paper that just came out a couple weeks ago describing what patients feel is an important component of an ICU recovery program. And again, it's probably a little bit more than we have time to go through today. But I just want to mention that in addition to the benefits we can provide to patients and families, there appear to be some mechanisms driving improvements back into the ICU. So if we see patients after they get home, we learn a lot about what we could be doing better in the ICU. And there are quite a few ICU recovery programs in the US now. Brazil, I hope you'll let me know so I can update my map. And if you are interested in studying this or working on getting a post-ICU clinic started, I'd encourage you to follow CAIRO. That's the Critical and Acute Illness Recovery Organization. Follow us on Twitter. We are a multinational group of interested physicians, nurses, physical therapists, and psychologists and others who are working together to try to get better post-ICU care for patients and families. And we're opening up new applications to join this group today. Thank you.
Thank you, Carl. That was a great overview. So we'll open now for questions. We have a few minutes.
Thank you, Professor Carla. Can you hear me?
Yes.
Yes. Thank you for your share in your speech, your knowledge and your experience about this case. A simple question. In your opinion, the post-ICU recovery of the COVID patients will be different of the all other critical ill patients based on what you show us, that the reduction of family visits, reduction of mobility, more time in mechanical ventilation. What's your opinion about?
Yes, it's a huge problem, and I didn't have time to talk about it, but in the corner of that last slide, I just mentioned the ISOLATE study. We actually are starting a new study looking specifically at the communication barriers posed by decreased family visitation, and I was just on service this past week, And it's such a huge problem. We haven't, like I've said, we've only seen a few patients who are now post COVID recovered enough to be home who were critically ill. So I don't anticipate, my guess would be that the problems are not that different in kind from what we normally see, but they are certainly going to be different in severity, especially the post-traumatic stress. So I was just on a call with the Cairo group on Monday, and we blissfully have not been overwhelmed in terms of COVID patients, and we've not had to do things like share rooms or ventilators, but some of my colleagues in New York and Michigan and other places have had to do this. So you can imagine a critical illness is already very scary. You're already delirious. Now imagine you're sharing a room with another person who has the same diagnosis as you, and you watch them code or die or have to be resuscitated, and you're sitting there awake, and that you could be next. So I expect the post-traumatic stress symptoms to be especially profound. We don't have the families at bedside able to fill in the history for patients to interpret real stimuli that turned into scary false memories for them, although I still encourage families to keep a record even away from the hospital. And we do also have a peer support group. So patients and family members can come in. It's actually also now all teleconference, so they can join remotely the support group and talk to other survivors. And it's facilitated by Jim Jackson, who's a neuropsychologist who sees patients with me in clinic. So we've seen a big demand for that. Jim also, as an aside, started a support group for staff and for physician faculty during this time, so that they can also talk about these stressors that I think in many physicians and other clinicians is going to result in post-traumatic stress.
Thank you.
Other questions?
Carla, nice to meet you. This is Jim Fleck. I'm very concerned about the physical consequences of COVID-19, post-intensive care syndrome. What do you think, or do you have already an idea what is the percentage of physical impairment of those patients after recovery? The total physical impairment.
Yeah, I mean, if we're talking about patients who've been critically ill with COVID, it's 100%. I mean, this is not a scientific study, but even pre-COVID, when we would bring people into clinic and do 6-minute walk distance, the median 6-minute walk distance, it was 47% predicted, and our average age was only in the 50s. So age is not protective. Like the young man whose picture I showed, he lost 126 pounds. A lot of that was muscle. A lot of that was fat too that he had to lose, but the physical weakness is profound. We've seen a couple survivors now who have some, the only thing that I've seen different so far in terms of physical impairments is some visual disturbances and possibly some brain pathology that hasn't been quite worked out yet in my mind, but has put me in touch with my neuro-ophthalmology colleagues, which has been really interesting and informative. But all the things that go along with deep sedation, paralysis, pressure sores, wounds. One of the things that's on the dirty dozen is, tell patients if they had, like, why do I have a big scar here? I had an ECMO cannula. If they have a DVT and they got an IVC filter, they're not going to know about that unless we write that down for them. So there's a lot we can do to remediate the physical impairments, but there are challenges on all sides. There are challenges on the prevention side, as I mentioned, and then there are challenges at the discharge point. So a lot of these patients, I would insist, go to inpatient rehab, an inpatient rehab hospital. But even if they qualify, at this point, everyone's so afraid to be in an institution that they refuse to go. And then the outpatient therapy options are also limited. So we're facing big barriers on all sides for physical recovery.
And are there too many patients with neurological disorders or cognitive disorders? And when you manage the delirium, it anticipates in certain way the form that the patient will be having these kind of sequelae?
Yes.
And complementing James' question, after Carla comments on it, I'd like to Matt or Todd to comment on the challenges of sedating these patients in the ICU, or Carla, anyone. I think that's been an issue for us.
Yes, absolutely. And, cognitive impairment is actually, I don't want to call it the norm, but in our pragmatic clinical population that we see, 65 to 70% have meaningful cognitive impairment as measured by the MoCA in the early discharge period. So that's usually 5 or 6 weeks after hospital discharge. And it's been very interesting to, what we can do over telemedicine is a little bit more limited as far as cognitive evaluation goes, but even simple things like count backwards from 7, or count backwards from 100 by 7, or remember as many words as you can that I tell you right now, has been very revealing. Even again in very young patients, cognitive impairment is there and probably significant enough to interfere with their daily function, but is not obvious in just a conversation, which is why you have to look for it in a systematic way.
Mm-hmm. Challenges on sedation of this patient population. You guys want to comment on it?
This is Matt. I can comment on that, and Todd, if he's on, can comment too. I was up in our COVID ICU last week, and this is, Todd mentioned our protocols and culture. So with Wes Ely and Carla and Pratik and everybody's influence here, we're an intensive care unit that is very systematic about trying to target light or no sedation. And I think there are COVID patients who tolerate that approach during invasive mechanical ventilation. And so we had at least 2 people who were on the ventilator on 90 or 100% FiO2, FaceTiming with their families, texting. But probably more common, it has been a degree of agitation that we do see during regular ARDS, but it feels to me subjectively to be more common here that patients are having a lot of agitation. We have a patient in our first bed who's self-extubated himself twice in the last 3 days. And so that we have had challenges of going from high levels of agitation to overshooting the sedation. And globally, and obviously there are some patients whose hypoxemia requires deep sedation and neuromuscular blockade. So I think the sedation has actually been one of the really fundamental challenges here. We've tried to be consistent about performing daily spontaneous awakening trials and spontaneous breathing trials in patients who that's appropriate, but the pendulum swinging so rapidly back and forth has made this more challenging than our average ARDS population to hit the right level of analgesia and sedation to keep these patients from self-extubating, but also not impair them with deeper levels of sedation than needed.
I think we have get to the end of the meeting, but I let John and Leah make the final comments now.
So I hope that was helpful. Obviously, it was a lot to cover in a few minutes. Now we're here rooting for you guys. I think that we are probably about two months ahead of you, and just do the best you can. I think this is we're in this for the long run. So we'll be happy to keep the dialogue going and be here to help you in any way we can in the future.
Thank you very much for all of you. It's been an amazing talk for everyone, which shows the quality of the Vanderbilt Center. And as I've read, and it's interesting, we sent you about 20 questions, you answered most of them. So it's very rewarding, and I'm happy we're having a bridge so we can learn from you. Since we are at the beginning, we first started in March 9, the first case. and in our hospital was on March 14th. So we do not have many patients. So I'm not going to have able to ask you more questions. We still have a lot to talk, but certainly we're learning day after day. So it's a self-process. So we really will be looking forward to knowing more from you. Thank you so much. I'm very delighted to listen from you.
Thank you, Leah. Appreciate it.
Thank you.
Thank you, Carl. Thank you, Matt.
Thank you for having us.
Thank you.
Thank you.
Bye-bye.
Bye, everybody. Thank you.
Thank you.